The next speaker will be Professor Lynn Cox from University of Oxford. Yep. All right. Just putting in Zoom. Thanks, Melody, for a very clear talk. I always struggle to wrap my head around these methods, and you made the explanations very clear. Thanks. So Professor Cox is going to talk about their BIRAX Awardee project, which is on age-related bone fragility in type 1 diabetes.
Right. Good afternoon, everybody. I hope you can see my screen.
We can't, Professor Cox?
You can't.
Can you
right.
switch the video on? Is it switched on?
Okay. Is that working?
The presentation is all right, but we can't see you. Now we can see you. Fine. Everything seems to be all right now. Okay.
Right. Well, thank you. Good afternoon. It's a pleasure to be here. And I'd like to start by thanking BIRAX, obviously, for the funding, but also my wonderful colleague and collaborator, Professor Rivka Dresner-Pollak, who unfortunately can't be here today. She's currently in the United States of America. So I'm presenting this on behalf of the collaboration. Now, our BIRAX award is to investigate bone fragility in type 1 diabetes. And this project is absolutely necessary because of a major success story in medicine. And the success story is that diabetes no longer kills people. So I've only got stats for the UK, but in the UK at the moment, there are around 400,000 people living with type 1 diabetes. We think of type 1 diabetes as juvenile, but in actual fact, only 29,000 of those are children, which actually means that we've got a very large number of adults affected by type 1 diabetes. And the incidence is increasing year on year. So we've just heard about autoimmune rheumatoid arthritis. Well, type 1 diabetes, many of you will be aware, is thought to have an autoimmune etiology. But interestingly, half of newly diagnosed cases are in adults over the age of 18. So as I said, this is a major success story. We're getting better at monitoring diabetes. We're getting better at treating people with diabetes so that they are living into older age. But with that success story comes quite a significant challenge. The aging per se, as we know from this conference, is associated with quite significant risk of a number of age-related diseases, and that health deteriorates even faster in people who age with diabetes. So in terms of the types of diseases that are associated with aging, obviously there's a huge range: cardiovascular disease, dementia, blindness, kidney disease and incontinence, immunosenescence, and among many other things, osteoporosis and bone fragility. And we know that those conditions go up with age, and as we get older and older, people suffer not just from one, but multiple different morbidities associated with aging. But with diabetes, it seems to accelerate the process. So we can think of diabetes as actually a premature aging syndrome. Now, we're looking particularly at bone health in diabetes because there is this major issue of an increased risk factor of bone breakage, and particularly hip fractures go up really markedly in people with diabetes. They also heal poorly, and there's a major increased risk of death post-fracture, particularly in type 1 diabetes. Now, of course, this is exacerbated by an increased risk of falling. So if people are taking hypertensive medications, they're suffering from hypoglycemia or vision defects through neuropathy, then they're more likely to fall. But that's not the only cause of this increased risk. There are multiple comorbidities associated with diabetes, including thyroid disease, celiac disease, rheumatoid arthritis, as we've just heard, pancreatitis. All these things increase frailty and fragility. And together with that, if there's childhood onset type 1 diabetes, there's lower insulin, and of course, that leads to decreased bone development and formation and mineralization in childhood, and decreased levels of calcium and vitamin D might also play a part. But there's something more to it than that. So bone mineral density cannot account entirely for the issues of increased bone fragility in people with diabetes. So what else is going on? And obviously insulin signaling is a key part of that, but what else? Is it uncontrolled blood sugar levels that lead to increased glycation? That's non-enzymatic addition of sugars to proteins and other amides around the body. Is it simply aging with diabetes? What do we mean by that? And could it be cell senescence, a major process of aging? So our project is aiming to look at 3 key points. The first one is to work out whether cellular aging or cell senescence actually increases with type 1 diabetes in bone. To then identify how increased blood sugar levels, so the glucose levels, affects the bone cells, and to actually come up with a molecular mechanism for that, if at all possible. And once we've got a molecular understanding, then to test new treatments that can reduce senescence and hopefully improve bone health. So the way we're looking at senescence specifically, we've already heard about senescence from Valerie Krashenovsky and various others in this meeting. And what we know is that cell senescent number goes up with age. And it goes up faster in people who suffer with premature aging syndrome. So we've heard about atypical Werner's syndrome, but also typical Werner's syndrome, Hutchinson-Gilford progeria. So premature aging is associated with premature onset of senescent cell accumulation, but also human conditions associated with poor health and decreased longevity, so things like obesity and diabetes. People living with those show an increased level of cell senescence. Now, Valerie has also pointed out that removing senescent cells improves health. And then the key experiment to show that senescent cells are causative in multiple diseases of aging was the injection of senescent cells into one part of the flank of young mice. And those mice then developed multi-system aging. So senescent cells can drive aging across the body. Now, senescent cells are harmful in many different ways, but particularly we know the molecular mechanisms of certain phenotypes of senescence. One is that they express very high levels of cell cycle kinase inhibitors, so they undergo cell cycle arrest, and this actually prevents them from contributing to wound healing because they can no longer proliferate. Senescent cells also adopt a secretory phenotype. We've heard a little bit in this conference about the SASP, and that contributes to inflammation and tissue damage. So metalloproteases will be secreted and break down collagens and basement membranes, extracellular matrix, and inflammatory cytokines can contribute to something called inflammaging. Moreover, senescent cells have a problem with proteostasis. So we've heard extensive talks, beautiful talks on proteostasis, and we know that senescence results in a failure of autophagy and also an accumulation of DNA damage. Now, senescent cells just hang around there. They don't die, and this is where senolytic drugs come in. They overcome this anti-death pathway of senescent cells. But what's important to note is senescent cells can be called zombies because not only do they hang around in a sort of undead state, but they also, through this secretory phenotype, can induce cells around them and even further away in the body to become senescent as well. So there's a spreading of senescence. And then finally, we know that senescent cells change in gene expression patterns, and in particular, genes that should be very tightly regulated end up being permanently switched on. So that gives a scope for potential interventions. Now, in the BIRAX project, we're looking at type 1 diabetes, and so we need to study it in a suitable model system. So we've chosen to use the Insakita mouse. Now, this is actually a mouse carrying a mutation in the insulin 2 gene, which leads to misfolding and formation of a toxic protein. And that toxic protein damages the pancreatic beta cells. So it's as good a mimic as you can get for type 1 diabetes, the autoimmune destruction of beta cells. And physiological measurements from these mice shows that the Akita mice have very, very high blood glucose levels, absolutely characteristic of type 1 diabetes, uncontrolled diabetes. And so for those of you who are used to measuring it in mg per deciliter, these are the numbers, and this is converted to millimolar for those of us who are more accustomed to working in those units. And this mouse is actually a very good model of diabetes. It's relevant to humans. The ranges of glucose in mice are not dissimilar to those in humans, normal humans and those with diabetes. So more than 7 millimolar is characteristic, fasting glucose is characteristic of diabetic patients. And these mice have around 23, 25 millimolar glucose in their blood. Now that seems extremely high, but we do know that higher levels are survivable. The highest recorded, at least on the Guinness Book of Records, is a 7-year-old patient in the States who was admitted to hospital with 147 millimolar glucose. Did survive, but obviously that's not something that's ideal and will cause significant ill health. So in these mice, we can start to look for phenotypes of senescence. And this is work from Rivka's group, where they've been doing a reverse transcription PCR and looking at levels of key senescence markers. Some of you might know CCL5 as RANTES, R-A-N-T-E-S. But all of these markers go up quite significantly in the Akita mice, the diabetic mice. So if you have a look at those red lines, you can see that wild type to Akita mice, there's a very significant, a significant increase in the markers of senescence very early on. So this is only 3 months into the mouse lifespan. So they're already accumulating senescent cells, and these senescent cells are actually positive for sclerostin. So these are actually bone osteocytes. So the Akita osteocytes prematurely show markers of senescence. And when you look at other markers of senescence, including DNA damage, this is looking at a characteristic older mouse bone, looking at sclerostin expression for osteocytes, and also H2AX, gamma H2AX, which is a DNA damage marker. And so as mice age, you can see these damaged foci within the nuclei, but actually in the Akita mice, you can get very premature, it's disappeared, very premature onset of this DNA damage phenotype. So the mice are showing characteristic phenotypes of senescence very early on. But what's driving this? Well, we know obviously that the passage of time can drive senescence and aging. We also know that exposure to environmental influences, pollution, and various other things, radiotherapy, chemotherapy, can drive senescence. Psychosocial stresses and cellular stresses can also drive senescence. But in the context that we're looking, there are a number of studies showing that actually sugar itself is a senescence inducer. So what we're doing now is to try and get a handle on the molecular mechanism is to study cells grown in culture in the lab. And for those of you who aren't molecular cell biologists, I thought I'd just show you what a lab looks like. For those of you who work in labs, you're probably horrified about this being in the hood. But anyway, this is a sterile cabinet where we grow mouse bone cells in little plastic flasks, and we can visualize them under the microscope. These are actually human skin fibroblasts, but we're growing mice cells as well. And the mouse cell line that we're actually working with is a precursor to bone osteocytes. It's called an osteoblast. And what we're using is a cell line that's been developed that is conditionally immortalized at 33 degrees centigrade. So it will carry on growing and proliferating as an osteoblast type cell until we shift the temperature and change the culture conditions. So we give it ascorbic acid, beta-glycerol phosphate, and that drives differentiation into mature osteocytes. So we have this rather nice model that we can bulk up the cells and then differentiate them in vitro. And we are looking at the cellular morphology, the degree of mineralization that these bone cells can produce, their gene expression patterns, their protein content, and their secretory phenotype and other phenotypes of senescence as well. Now, you won't be able to see detail in here, but this is just an indication that over a month, under normal glucose conditions, these cells will start to deposit mineral, even in tissue culture dishes. And so these sort of birefringent barnacles, as the postdoc Thibault calls them, are actually mineral deposits akin to that of bone. And then when we look at the diabetic bone, we think we're seeing less mineralization under high glucose conditions reminiscent of the glucose seen in the blood of the Akita mice. So this is at 25 millimolar in tissue culture. So what we've been doing so far, Rivka's lab have been conducting some studies. Oh, sorry, this is just to show you the mineralization in more detail. So Rivka's lab has been conducting RNA-seq analysis and also analyzing the SASP, and we've been looking at phenotypes such as senescence-associated beta-galactosidase, a marker of senescence. And what we can see is as we increase the glucose conditions, we get more blue. So this is just looking at a 96-well plate, but it's a rather nice indication of a concentration-dependent increase in SA-beta-gal, a marker of senescence, which is not mimicked when we use an osmolarity osmotic control called mannitol. And then Rivka's group has shown that these cells cultured over a month start to produce a marker characteristic of the senescence-associated secretory phenotype, something called HMGB1, is released from these cells into the culture medium. And we know that HMGB1 can actually trigger further senescence pathways, particularly through inflammation, through this RAGE signaling pathway. So culture conditions that drive diabetic type conditions in the lab also drive senescence type phenotypes. And now my computer seems to be a bit stuck, so sorry about this. So what Rivka has now been doing is looking at gene expression patterns using RNA-seq. And in principal component analysis, it's very clear that the cells exposed to high glucose are a very, very different population than those exposed to low glucose, which are the blue dots and triangles here, and also the osmotic controls with mannitol. And looking at the number of genes going up and genes going down in response to these conditions, you can start to do some pathway analysis. And you can see very clearly that there's a major difference between cells incubated under high glucose versus low glucose or the mannitol controls. And the very preliminary pathway analysis that we've done suggests that there's all sorts of things changing, but particularly in terms of cell division pathways, signaling pathways, fibrosis, osteoporosis, rheumatoid arthritis, so all things associated with bone, which we might expect. Now, we've also been looking at proteomics levels, and what I'm going to show you very briefly is just a pathway that we're particularly interested in from previous work we've been doing, looking at proteomic changes on senescence, so comparing old and young cells and doing molecular spot the difference. Looking at pathways that are up and down regulated in the old cells, and particularly this mTOR signaling pathway that we've heard about several times during the course of this conference appears to be permanently switched on in our senescent cells. So it's the tap that's left permanently on. And obviously we all know what happens if you leave the tap running. It's not good for the fabric of your house. So what our aim is to just regulate that tap now, turn it back to where it was in younger cells. And so what we're aiming to do is look at these senescent cells, use inhibitors, drugs like rapamycin, that can actually reverse some of these senescent phenotypes. We've got second generation drugs now that appear to be more potent. So the first generation drug rapamycin delays the onset of senescence. The second generation inhibitors actually improve the phenotypes even more and allow the cells to proliferate for longer, giving them capacity to repair and heal tissues. And so what we're doing now is testing those drugs in the bone cells in culture. And so this is just looking at some of the morphologies. And then I'll show you where we're at in this particular experiment. If you have a look at the dates, this is a particular experiment that was started a month ago, are going to be harvested this evening. I'm back in the lab tonight. And we're going to be looking at the RNA-seq and proteome of these. Now, in terms of other mechanisms, we're also looking at the direct impact of sugar on proteins, so glycation on enzymatic changes to proteins, because we know that this can cause collagen cross-linking, amyloidosis. We've heard a lot about amyloid in this conference, increasing extracellular matrix stiffness, increasing senescence and inflammatory signaling. So we know that increases in blood sugar can impact through this whole pathway with accumulation of glycation end products, leading to bone fragility. So in summary, what normally happens in bone is there's a nice balance between bone formation through osteoblasts and osteocytes and bone resorption through the osteoclast. In diabetes, and obviously insulin is influencing that. In diabetes, we've shifted the balance towards bone resorption. We have the inflammatory secretory phenotype that is causing harm. That inflammatory phenotype is actually also driving further senescence of osteocytes and other cells within the bone marrow, and potentially also driving adiposity, so there's fat deposits in the bone. So we're starting to get a handle on the molecular mechanisms and hoping to get some data from the in vitro studies that we might be able to move first into mice, and then if they're looking positive, into human clinical studies. And then finally, again, thank you so much to Rivka. This is Rivka here at the awardee ceremony in Israel, and this is me here at the awardee ceremony in London simultaneously. And to Vlad Temkin, the postdoc on the Israeli side of things, and to the postdoc in Oxford, Thibaut Tessier. And thank you so much to the BIRAX team, the British Council, and Diabetes UK, because obviously none of this could be done without you. So thank you very much. I'll stop sharing now. I don't know if we've got time for questions.
Thanks very much, Professor Cox.